to talk on odontoid fractures and new surgical treatment. I have no disclosures except my teacher, Professor Ramani, and my wife, who is my anesthetist for the last 30 years. So we all know that odontoid fractures are classified as type 1, type 2, type 3, and that type 2 are offered surgery. But odontoid fractures are not simple fractures. They can be associated with hangmans, with Jeffersons, with so many other injuries. So this classification of D'Alonzo is quite incomplete as far as treatment is concerned. Odontoid fractures in young people are different. They're usually very complex injuries because odontoid fractures are associated with a lot of ligamentous disruption in young patients, whereas in elderly, it is a simple fracture and 50% can heal even without surgical treatment. If you will see the natural history of type 2 fractures, non-union is seen in about 80%, and instability can come in up to 7 years. And the decision depends upon how much separation is there and whether there's subluxation and age of the patient. You have to ask yourself, why do we operate odontoid fractures? We operate odontoid fractures either because there is instability or there is going to be instability in the future like this. Because of avascular necrosis, there will be instability, or it will go into malunion and cause cord compression. So most of the operations, if there is no instability, are actually prophylactic operations for instability in the future. If you will see that after Nakansha and Bowler described the technique, it has become the most popular technique for treatment of odontoid fractures. But there is very little level 1 evidence to tell you that odontoid screw is a very good treatment. There is a lot of complications. People have yet to review the literature properly. Nobody has published level 1 evidence that odontoid screw is a very good operation. Yes, posterior C1, C2 fixation is a good option, but in elderly people and in patients with a lot of instability. If you see all the recent literature on odontoid fractures, it focuses on the geriatric population. This is a completely different disease. Geriatric population, see the recent literature, most of it is based on posterior C1, C2 fixation or anterior screw in geriatric population. But odontoid is different. As we become older, odontoid also changes. Passing an odontoid screw in a geriatric population can be catastrophic and can fail. We have to remember that odontoid is not a weight-bearing bone like the humerus. In the humerus, you never pass a screw, intermediary nail. You always fix with plate, and you, unlike the femur. And similarly, this is posterior fixation actually is a kind of external fixator. It does not act on the side of the fracture. Also, when you do both these operations, see for screws, if the neck is short, it is difficult. The transverse ligament has to be intact. The fracture line should be horizontal to the passage of the screw. And anterior technique should be performed only if adequate alignment can be restored. It cannot be done if it cannot be restored. But fractures don't read textbook. When you pass an odontoid screw, the screw must cross the distal cortex. There must be adequate bone in the front, and the screw head must sink into the bone. And to do that, you have to damage the C2-3 disc, which itself is subjecting the C2-3 joint to increased stresses. If the screw is not perpendicular, this is what will happen. You have to have the screw perpendicular to the fracture. Patients and fractures don't read textbooks. Now see, this is an example what has happened. The screw has not gone beyond the distal cortex. The screw has not sunk inside. There's very little bone in the front. This is doomed for failure. It is going to come out. Another example, what happens when the screw fracture is not properly reduced and associated with instability, the screw has walked inside. So screw is not a very simple operation. It requires, there are too many requirements. Posterior C1, C2 fixation is a good option, but always there's a risk of injury to the artery. So what are unstable fractures? Those where the LR ligament has got disrupted, there is loss of facetal alignment, there is a combination of the fracture and the displaced odontoid fragment, fracture involving the superior facet and fracture associated with Jefferson and hangmans. New concept, direct open reduction of fracture fragments, VSP plating under compression and bilateral transarticular screws anteriorly, a single treatment to treat any kind of displaced fracture. So this is an anteriorly displaced fracture. It is reduced, positioned, and then anterior transarticular screws or plating can be done. This is the kind of plates that I use, which is manufactured by the Jeon company in India for me. So any fracture can be reduced and brought into position and treated by this technique of described by me. So this is an example. I'll just show a short animated video. So when you do your orthopedic surgeons, you know the VSP principle that will compress the fraction, that will give the best results in a non-weight bearing bone. So you got an anterior slanting fracture, which is a contraindication for the screw. So put a plate and fix it with a screw, compress the fracture and enhance the healing of the fracture. Similarly, in a displaced fracture like this, which would have ended up in transoral odontoid excision with posterior C1, C2 fixation, you can impale the fracture, reposition it, pass the plate anteriorly, and then pass bilateral transarticular screws to compress to fix the atlantoaxial joints, and that will complete the treatment of the instability also at the same sitting without wanting to turn the patient upside down. You can impale the odontoid like this and bring the odontoid into position the way you want it. With this series example of posterior displaced impacted fracture has come to me after 2 weeks. This would have ended up in transoral odontoid excision, but I've repositioned and passed anterior transarticular screws. Another example where I this is again impacted fracture, repositioned, realigned, and you can see that there's fracture healing. The end point of odontoid fracture treatment is that the posterior cortex should reform and the fracture should fuse. Don't get impressed by the implants, get impressed by the fracture healing, which should occur at the end of 6 months. And if that has not occurred, then the treatment is incomplete. This is another example you can see, fixed with the VSP compression plate in compression mode. This is another example you can see. And you can see that when you put the patient extension, it is a bad case. You cannot pass a screw because the fracture dislocates. But then when you do the plating, you can see over a period of time, the fracture has healed because it is in compression mode. This is another example you can see repositioning, and this is the implant plate screw in the center with bilateral anterior transarticular screws and long-term fracture healing with remolding and healing of the fracture. This is another example, and in 3D example to show how the plate sits. You know, this is how it is. The plate sits in compression mode and and plus the anterior surgery permits you to put a lot of bone into the joints. You can prepare the joint with a micro drill and pack it with bone, which you cannot do with posterior surgery. So this is the implant construct. Another example of a malaligned impacted fracture, repositioned, realigned, and fixed. This is another patient with a associated hangman's fracture. So that is treated by anterior plating in addition to anterior transarticular screws, a long-term fusion across the joints. This is one more example. Another example. So the end point of odontoid fracture treatment is that the odontoid should be reformed, the posterior cortex should be reformed, and in unstable fracture, the joint should fuse. So all this can be achieved at one sitting from the front in 95% of the patients. Now this is a locked facet where it was impossible to reduce with traction. So this patient is explored, the muscles are cut, the longus capitis and longus scoli, the odontoid is impaled, repositioned, and bilateral anterior transarticular screws are passed. And you can see this hole for impaling the odontoid. And this is how it looks, and this is how the fracture heals over time. This is another example. So there are some complications like hoarseness, marginal mandibular weakness, but most of them are resolved by 2 weeks. I've had one death because of myocardial infarction in the patient. This is unclassified odontoid fracture, vertical fracture associated with the hangman's fracture, not reducing with traction. This patient is treated by a plate on one side, screw on one side, and discectomy is a long-term result. And you can see that the advantage of this operation from the front is the neck movement remains unrestricted. Unlike doing a posterior oxygen, this patient would end up posterior fixation, and the neck movement would have got restricted. This is between the muscle planes. No muscles are disrupted except for the longus scoli. This is another example where I've treated with anterior plating both the fracture odontoid and the Jefferson's fracture. So classification is incomplete. Displaced impacted fractures, comminuted fractures, osteoporotic fractures, and associated fractures are not addressed by the classification of D'Alonso. We need to review the classification, assess all the associated injuries. So this is another example of a chronic fracture which is treated by bilateral anterior transarticular screws. My technique got published way back in 2017 as a direct compression reduction fixation in neurological research in 2017. Subsequently in neurosurgery, no CM, no navigation, vertebral artery injury, 0% because the vertebral artery is not in your way. Of course, in operative neurosurgery, those who are interested, they can read about it. So what is the difference? The difference is that this area is not responsible. In the fracture, you have to only focus on the fracture. You go directly to the fracture, disconnect the longus scoli and the longus capiti muscle, and you're on the fracture. There's no point in disrupting this entire posterior muscle complex and the posterior tension band to treat the fracture. The fracture is always, the fracture displaces anteriorly. Posterior surgery is adding insult to injury. You have to study where is the force nucleus, where is the line of weight transmission, what is the quality of the bone, and whether the technique is safe, simple, and anybody can do it. See, from the front, there is nothing you expose, it's less anterior cervical fusion. Pass the screws bilaterally into the bone, prepare the joints, clean the cartilage, put bone pieces inside, and in supine position, the fracture is going to reduce. And you pass the screw, you do not require much instruments. See, this is an example how it's done by passing bilateral anterior transarticular screws. But then sometimes there are surprises, if you don't get adequate amount of bone, it can fracture, the screw can misplace, like it happened in this case. So I just published a new technique for basilar invagination, which consisted of anterior implant where you take bicortical purchase on C2 body and pass screws directly into both the lateral masses. So the same technique I used for odontoid fractures. And you can see this is the technique. This was the plate devised by me, and you can see the fracture. You can pass the screws and lateral mass without any fear, without having to worry about how much bone is there between the screw. And this is how it is fixed. And see, the example is a long-term result where you see odontoid fracture being treated by my technique. This is the pre-op and post-op at 1 year. This has been published just last 2 weeks ago in Journal of Neurosurgery Case Lessons. Those who are interested in reading about my technique, the videos and the technique is there in JNS Case Lessons. I feel that posterior surgery for odontoid fracture, I think, is a surgical overkill and will eventually go out of the window. So the new option is that it adheres to principles of fracture treatment as a direct open reduction and fixation, single operation for all type of fractures, no risk of injury to the vertebral arteries, and a very flat learning curve. The videos are also available in Journal of Neurosurgical Focus, all those who are interested in this. And you see this famous Egyptian pyramid where you can see these videos are put up on in JNS. They are freely accessible. All those who want to learn the steps of the surgery, they can see them in the JNS. Message: fracture alignment, fusion are the endpoints of treatment. Fusion of the atlantoaxial joints is mandatory if the patient has got instability. Direct open reduction and fixation is possible in almost all cases. Anterior plate screws are very quick and easy. There is no risk of injury to vertebral artery. Is there a better way? You should always struggle. Truth will come out of error than from confusion. We should not be dogmatic of what we are doing. And the last but not the least, I'm going to show you one more technique. This is the technique, this was Atlas who was cursed to carry the earth on his shoulders. I have devised an operation to change this. This was published, shown in ANS, and then published subsequently in Journal of Neurological Research. So see, this is a patient who has undergone incomplete excision of the odontoid, and the atlas and axis are infected. There is no way to hold, plus there is infection in the posterior wound. So this was a new operation devised by me, transferring the weight of the skull to the anterior cervical spine. And this is a long-term result where flexion extension, the implant has done well. This is another patient of fibrous dysplasia where there is nothing to put the implants. Even the posterior spinous processes are involved by the disease process. So this patient was also treated by this technique of transferring weight to the anterior aspect of the spine. And it's a very novel technique published by me a couple of years ago. So you can see it just involves the anterior cervical exposure, going lateral to the spine, identifying the transverse processes and going on the C-arm. And the area outside the transverse process is a safe area. These are customized rods made for me by Geon company. I have no financial interest with Geon. The rods are pushed inside, and once they are pushed inside, there are connectors which fix them to the vertebral body, and they are on the lateral side so they don't encroach upon the esophagus. So this is fixed. Then the patient is turned prone because the rods have come out in the paraspinal region. The patient is turned prone. I do not open the midline. I just take paramedian incisions where the bone is thick and fix special plates to the skull. And rod is passed from that plate. This plate is fixed where the skull is thick as decided by the CT scan. Then using a domino connector, a rod is passed from here into there are one incision on the rod tip and one on the skull. The rod is passed and you can reposition the fracture, pathological fracture. This is used when you are unable to fix the C1, C2 region for whatever reason. So this is the final construct. This is the patient preoperatively. You can see the pathological fracture because of the fibrous dysplasia, and there's hardly any bone available. And then it is fixed. This patient gets up. She was in bed for almost 4 months, and then she's able to walk, and she's very happy. and she's very thrilled with what has happened with her. And you can see this over a period of time. This was, about 2 years ago when I published this case. Subsequently, I've done a few more cases, but the bone has reformed. The patient has been on Demosab. Thank you very much, my dear friends, for your attention.